Okay, now let me just say in English, instability chronica, chronic instability you can deal with. Chronic dizziness you can't deal with. There's no such thing as chronic vertigo. Physiology tells you vertigo has to be acute and has to get better. So somebody who says to you, look, doctor, I'm spinning all day, every day, the best thing to do is to go to sleep. Wait till they finish talking to you 5 hours later, because you will never solve that problem. Okay? It's impossible. In other words, this is why it's really important to understand physiology, because you will know what is impossible. You can't keep spinning because the vestibular nuclei recover. Okay? You can have intermittent vertigo, but somebody who says, I am spinning every day, all day, well, that's very interesting. I think you need a holiday. But this is people who are off balance. So look, doctor, I really feel unstable, and you may have said I've had some falls. Once they've had some falls, that is serious. I mean, there's statistics showing in elderly people, once they have more than 5 falls a year, they only last 2 years. So repeated falls in elderly are the, I don't know if it translates to Spanish, part of the slippery slope. Okay, so you have to take it seriously. Now, actually, I can watch here. What you really do need to know is what happens after a total unilateral deafferentation. Now, what I'm talking about is somebody who suddenly loses function of one intact labyrinth. Now, this is new information. Flourens did all this work in the beginning of the 19th century to pigeons, but what we know is that this applies to humans with a different time course. So I just want to remind you that after a severe acute total unilateral loss, so there's somebody who loses one side which was functioning normally, loses it suddenly, either through some disease or through some interference. And there is good compensation for the acute deafferentation syndrome, which we all know, the vertigo, the nausea, the nystagmus, blah, blah, blah. We know all that gets better. And there is no recovery of the periphery. In other words, you've cut the nerve, or it's a vestibular neuritis that hasn't got better. In other words, they suddenly, permanently lose vestibular function in one ear. About 30% of those people will be forever as unhappy with their balance as a person who's lost both sides. Someone who's been filled full of gentamicin, that's the usual cause of that. Okay? And if you do any test on those people with what we call the happy unilaterals versus the unhappy ones, there is no difference. The sensory organisation test is the same. One of a shared PhD student with Ian Curthoys, who was a clinical psychologist, wrote a 2-volume thesis on the psychology of these people, and the answer was, who knows? So these aren't all obsessive compulsives who can't tolerate a little bit of imbalance. And of course, the contralesional, the normal side, is actually normal, and the only way you can show that is with head impulses. So these people, the explanation is not that these are the people who've had a subclinical vestibular problem on the other side. And by taking away the good ear, you have revealed that their other ear is not that good. It's not true. So if you look at a large number of happy ones and not happy ones at the intact ear, it's the same. So I don't have an explanation, but if you look at their dizziness, handicap, inventory, anything else, they are truly unhappy. Now, of course, if this happens following labyrinthitis, it's not your fault. But if it happens after you put gentamicin in the ear, it is your fault. So the answer is warn them. So if you have someone with many ears who needs intratympanic gentamicin to stop the vertigo attacks, very good treatment, says, I will do this for you so long as you realise there's about a 1 in 3 chance that your balance will feel permanently not as good as it was. Nobody can see any difference, but it will feel wrong to you. So you will think that every time I walk, people think I'm drunk. But you can't see anything. But they get this sort of slightly paranoid idea that their walking isn't right. And I have no idea why this happens. As I said, we've looked all the way from physiology to psychology, and I don't have a convincing answer. So some of you may have seen these people after, you can get it after vestibular neuritis. Neuritis is gone, vertigo is gone, you look at it, all the functions, compensation is complete, they're just unhappy. Look, my balance is not good. They can ride a bicycle, they can ski, but they're not happy. And I don't think the answer is going to be in their psychology. I think it's the physiology, and we just don't know why. But the point I'm making, if you're going to deliberately remove unilateral vestibular function, mention that, okay? Because, you know, certainly in my country, failure to warn is good for lawyers. This is, I think, an absolutely masterly article which discusses this and other matters from Michel Lacour, who's been working on compensation in animals and men for a long, long time. This is a free article in Frontiers in Neurology. By the way, I'm going to give all my slides to Dr. Perez, and he'll make them available. So these references, you don't have to scribble down. They'll all be on the slides. But that is really a masterly review. And it discusses this problem, too, of why some people with a total unilateral loss are so unhappy with their balance. Okay, now you'll probably all know this one, but this one we need to know. Very simple test.
No, start with your eyes open. Right.
So he's closing his eyes and I'm asking him to march on the spot. Okay? But when you do this test, you must keep talking to them. Keep your eyes closed, do not open your eyes, and I'm talking.
Just try very hard to stay in one place.
Try very hard to stay in one place.
Don't open your eyes. I'm reading.
His eyes are closed.
Just it, that's right. You can put your feet a little wider apart to walk. That's it. For stability. That's good. That's good, but stay in the one place.
Very cheap, simple test.
Keep going, keep going, keep going, keep going.
Now he's going to run into me, so I'll tell him to stop, but not open his eyes.
So keep going, that's excellent. Keep going, keep going, keep going, keep going. Now keep your eyes shut. Keep them shut and stop. Keep your eyes shut and stop. I'm just going to push you back very slightly. Move back, but with your eyes shut. That's it. Move back. Move back. That's it. Now start to walk again with your eyes shut. Okay, off we go. That's good. Keep going. Keep going. You're doing really well. Really well. Really well. Really well. That's good. Keep it up. Keep it up. Keep going. Keep going. Good. Keep going. Keep going. Keep going. Keep going.
Instructions are critical.
Excellent. Okay. Now stop and open your eyes. And how did you start off? Go back to the position you started.
No idea. No idea. Okay? So that's what you get with someone who has had a partially compensated right loss. Okay? But you need a cooperative person. I mean, somebody who wants to be hysterical, demonstrative, they'll fall over the ground and, you know, crazy stuff. Okay. So that is a quick and easy way. Now, that doesn't mean he's got imbalance, right? But it usually goes with it. Somebody who has imbalance after unilateral loss will usually have this positive marching test, whether you call it by a Japanese or a German name. Okay. Now, this one you all know, but it's a very expensive test. Okay. In those days, I only had a little camera, so I couldn't get the whole picture. Here he is, okay? So he's standing on the ground, absolutely completely normal Romberg test on a firm surface. No problem at all. He was sent by a fellow neurologist. Look, he says he's off balance, but I can't find anything wrong with him.
Stop.
Now, this is the expensive apparatus.
Got that? Yep. Okay, looking straight at the camera.
Adjust the collar, very important. Close your eyes.
Now close your eyes.
Okay, that's it. Diagnosis made. Now, Quite a few people with a severe unilateral loss will also have that. No, we don't want that. Will also have that. Okay? So that tells you there's a severe vestibular loss, but it may be mainly unilateral. But that is, in fact, the vestibular-Romberg test. I don't know of any neurologist who does this. Maybe it's too expensive having a cushion or something. Okay? There's a very nice French one, which actually is small and flat, actually fits into your briefcase. You don't need that big one. But without that, you can't tell the difference, is the balance due to the vestibular loss or non-vestibular. And with all the people off balance who are sent to me, that's the key test to do. In other words, if the elderly person says, I'm off balance, but they can do that test, it's not going to be vestibular. Nothing's absolute. But if somebody said, look, I've had some falls and blah, 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 and they can stand on a mat with their feet together, eyes closed, it's not going to be a vestibular problem. It's going to be something neurological. Okay? Very useful for you, because then you say, it's not going to be my problem. And when you combine that with a head impulse test, you've got a complete answer. So if your patient sent you off balance, is it vestibular, normal head impulse, normal foam Romberg, out the door. Okay, now I just want to remind you that posturography is a lot of fun, but it doesn't give you any information you can't get other ways. And of course, the posturographic equipment used to, cost more than a 500 BMW or something. But it's become a lot cheaper because you can buy a Nintendo Wii board and use virtual reality goggles. So posturography, and there's a paper from combined team from Sydney and from Paris. And again, that's a Freely Available article, and gives you a very good idea of how cheap it is now to get objective measures of balance. Because, after all, standing on a foam mat is not that objective. It's a yes or no. This actually can get measurements. So what I'm saying is that measurements of posture are being reinvented in a very affordable way. Now, I want to talk to you about this canvas business before, not because this is a common disease, this is a rarity, but again, it illustrates certain principles of balance. And where this is a unique situation is you've lost all three arms of balance apart from vision. The proprioceptive side, the vestibular side, and the cerebellar side. And what sort of constellation of manifestations that has. Now, if this will play, that'd be great. Okay, here it is. Beautiful. Thank you. As you see, he's looking to spot on the ceiling. I'm turning his head from side to side, and the eye movements are saccadic. Nothing else does that, almost, apart from canvas. Okay? So he has no smooth compensatory eye movements. So this guy's vestibular system is gone, plus his cerebellar system are gone. Because even if he had one of them working, this would be smooth. Because either vision or vestibular input can produce that. Thank you very much, that's great. If we could go back to the PowerPoint. And really the point of showing this is really for understanding. Now what you can see here, now how do I use have I got a mouse or an arrow to show? If I had, that'd be great. What you can see is this guy's video recordings. The bottom one, we measured him back 2000, and the top one, we showed him in 2010. It was the same. The bottom one was done with search coils, and what you can see there is the black is the head velocity, and the red is the eye velocity, and you can see there is some smooth eye velocity, but lots and lots of saccades. 10 years later, there's a pointer there. But that can only be on one screen. Oh, well, we'll live with that. We'll live. Yeah, that will live with that. Which is the... Oh, that one. We'll just live with that. Okay. What you can see there, if you look at this screen, is that this is now 10 years later with the video, with a precursor of the odometric system. And odometrics now have a VVOR test in there. Okay, so now it's easy. I mean, this took a tour de force to do that, but now it's trivial. You just plug in your odometrics and you get that. And what you can see that, in fact, he has virtually now no smooth eye velocity, it's all saccadic. So he's deteriorated in 10 years. I mean, that's not surprising. And then his pathology showed what I showed you yesterday, is that the vestibular ganglia are gone. Now, this is another very important sign in people with off balance. This is absent visual suppression of vestibular nystagmus. You turn someone from side to side.
Here we go. Out to the right.
They think, is that normal? Of course it's not normal. Normally you shouldn't see anything.
Right.
Okay? Now what's really, really important about this, from this you know he's got to have a normal vestibular system, but he's got no cerebellum.
Good.
It's a very nice test of vestibular function, but what's missing is the suppression of vestibular function, which is through the cerebellum. Nothing else does, nothing else does that. Okay? So somebody is off balance. One of the mandatory tests is to, if a VOR is normal, can he suppress the VOR? So what I've shown you here is the vision adding to the VOR with canvas, and here subtracting the VOR. But of course, if you take somebody who's got a canvas vestibular loss and look at their suppression's perfect because there's nothing to suppress. So you have to do these mathematic or arithmetic in your mind. Is vision adding or subtracting? Is there any vestibular to subtract anyway? Okay? So it's very important to understand the relationship between visual and vestibular compensatory eye movements. And most of them are testable clinically. You don't need, I mean, it's very nice. Odometric system also has VOR suppression. Okay? And slight degrees are important. But a slight degree of VOR suppression abnormality, don't immediately think this person's got some terrible cerebellar problem. Bring them back one evening when they haven't had a bottle of wine the night before. Okay? Because all of you could have very abnormal VOR suppression at about 11 o'clock tonight. You can look at each other if you like. Okay. Now, this is VOR suppression. This shows the beauty of VOR suppression because this is in one direction. This is a very rare patient who had a flocculus tumour, and her VOR suppression was only abnormal rotating towards that side. So we know straight away that basically VOR suppression is done in the flocculus. Okay, you can see when the person rotates to their left, they can't suppress, rotate to the right, they suppress beautifully. So not only is it cerebellar, it's highly lateralized. Now that's an exceptional case, you don't see that often, but what you'll see that it is clearly in the cerebellum and clearly in the flocculus and clearly ipsilateral. This is just to show you the smooth pursuit. This happens to be a cortical case, but what you can see here is the pursuit. That way is not much good, it's better in that direction. That goes very much with VOR suppression. But we always test smooth pursuit, can someone track? But an older person who loses attention may not do it that well. So you've got to be very careful when you look at smooth pursuit because that doesn't require a vestibular system, it needs a cerebellum and a brainstem. If someone can do it well, you take an elderly person who can pursue well, they're probably not much wrong with their brain. It's a very good screening test for the brain, certainly the balance part of the brain. Okay, now this is an interesting nystagmus which is specific for cerebellar disease, not that hard to see if you know how to look for it. This is rebound nystagmus. Looking straight ahead, the person has no nystagmus. Looking left, they get gaze-evoked nystagmus, which decays. When they make saccade back to the centre, they get nystagmus in the other direction. Absolute typical. This has been known 50 years, rebound nystagmus, but if you don't look for it properly, you won't see it. Look here, look here, look here. You've got to look for 30 seconds and then watch their eyes when they come back to centre and you see nystagmus the other way. Simple, truly simple. Okay, now, I'm not going to give you a great cerebellar talk, but just to show you there are some treatable causes of cerebellar ataxia. They're not many, they're mostly degenerative and nasty, or various degrees of nastiness, like most of neurology, but there are some treatable causes. This is cerebellar ataxia associated with glutamic acid decarboxylase antibodies. Now, GAD antibodies are found in diabetics in low titer, but a really high level of GAD antibody usually means an immune problem in the brain. And these Japanese authors are telling us that even a low level of anti-GAD is important. I'm not sure I believe them. Well, let's see if that's replicated. I mean, there was this same story about celiac disease. Some of you might have caught up. Anti-celiac antibodies make you ataxic. Complete rubbish. But the GAD antibodies in a high-level matter. Now, again, you probably won't order this, but when you send it to your neurologist, it may be a point reminding him, or actually ordering the test and sending with the test result. The only point of all this is there are some treatable causes of cerebellar ataxia. Okay, now, again, I want to show you a case which is a balance problem. This is a woman who came to me with vertical diplopia, ataxia, nausea, no vertigo. No matter which way I asked her, she said no, 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 and she was a headmistress of a school, so you couldn't argue with her. That's it. Okay, and she had a hypertropia, okay, with a left eye low, unequivocally skew deviation, right beating spontaneous dysnagmus, left Unterberger test, no head tilt, clinical head impulse test was abnormal. Now, this is why I told you yesterday, you've got to be careful of skew deviation, meaning brain. No hearing loss, no migraine headaches. And here's the skew deviation. You can see that the left eye is about 6 diopters lower than the right eye. Okay, you can see the reflections in the cornea. And that's what she was worried about. It's the double vision. And there's the fundus. What you can see here is both fundi are rotated to the left. Okay, so this is what we're talking about. She's got an ocular tilt reaction. Okay, and if you go back, and you probably just see her head is a little bit tilted to the left anyway. But of course, head tilt alone means nothing. Lots of people have head tilts. And here's the subjective visual. You know, it's nearly 24 degrees to the left. Enormous. No vertigo, doctor. Stop asking me. I do not have vertigo. Okay. And here's a head impulse test, which was clinically positive, but there you can see it very clearly there. She's lost the lateral and mainly the lateral canal. Well, I should be pointing there, mainly the lateral, but also a little bit on the anterior. Okay? So she's got an acute peripheral vestibulopathy. Here are the vamps, and you can see that the O vamp has gone from the left ear. The other O vamp's fine, and the C vamps are fine. Okay? Everybody happy with that? So it's all in the left ear, right eye, obviously, for the O vamp. So she has an absolutely typical superior neuritis, but no vertigo. Now you think she must be, some insensitive. She was not insensitive, and she was absolutely methodical. So I have no answer for you, but what I'm saying to you is it's not the first one I've seen. People who turn up with imbalance or some other component of an acute, but no vertigo. And you think, I can't believe it. This can't be acute. It has to be chronic. And of course, she actually got better, so it was clearly acute. Okay, now this is an example from Ian and Manzari showing I've shown you a vestibular neuritis that doesn't get better. Here's one from them. You can see here, there's a vestibular neuritis there on the left, and there it's got better. You can see here too that there's the O vamp's gone and the O vamp's come back. So a lot of vestibular neuritis, not a lot, I don't know how many, somebody will study this. Vestibular neuritis can get better. Okay. Now, there were lots of studies done, steroids for vestibular neuritis, but those studies were done with caloric testing. Okay? So I don't know how valid they are. I mean, everybody gives everything steroids, so if you want to treat your patients with neuritis with steroids, that's fine. If you don't want to, that's fine as well. I don't think it makes much difference. Okay, next one is a 78-year-old Greek man, again, vague vestibular symptoms for 15 years, 2 minor positional attacks, nothing very exciting. He was a native Greek speaker. Those of you who remember your Latin will know what I mean by timeo daneos, and the vestibular exam is normal. He says he's been deaf in his left ear since his childhood with infections. The Weber went to the left, the Rene was bone better than air. He was seen I must have been more than 10 years before by another neurotologist who ordered Clorix, audiogram, temporal bone CT. They were reported as normal. I had the original audios, but I couldn't get the CT films. And here's his audiogram. Now, this in 2001. What you will notice there, he's got, as we thought, a conductive loss on the left. That's obvious, a conductive loss on the left. And he said he had infections in childhood. But the key finding is that despite that air-bone gap, he's got acoustic reflexes. Somebody there knows, okay? That's inconsistent. This is where, again, you need physiology. Most audiologists won't pick that up, that if you've got that sort of air-bone gap from middle ear, you can't have reflexes. So either you don't know how to do the reflexes, or he doesn't have a middle ear problem. Those two things do not go together. But this was missed by people in 2001, which is not that surprising because what he's really got, of course, wasn't all that described. Now, these are video head impulses with our own system. What I want to show you there, I'm pointing at the wrong place, of course, is that his, where are we here? He's 78, his laterals are not great, 0.8, but that's okay. But what I want to show you is that his right anterior is worse than we expect. Often the posterior is a little bit worse with old age, but his left anterior is not that good. I think some of you might see where we're going. Now this is just showing in a different way. You can see both the laterals are not good, his posterior is not good, but that's because he's 78. But if you look here, the right anterior, here's the left anterior. It's not good. So as well as what I considered an age-related problem in his laterals and posteriors, he had an unexpected problem in his left anterior. That's just another way of showing it. Okay, and this is just with the odometric system. You can see it there too. Okay, left anterior slightly reduced. By itself doesn't mean much, but in the context of that air-bone gap with normal reflexes, it means a great deal. Here are his vestibular-vagal myogenic potentials. What you'll notice that over here, from the right ear, that means right eye, from the left ear, the one with the air-bone gap, he actually has a very nice N10. He doesn't have one from the right ear, in the left eye. And with the C-vamps as well, so from the right ear, he's got no vamp, but from the left ear, he's got a big vamp. This is the ear that has the air-bone gap. These are air-conducted vamps in somebody with an air-bone gap, 40 dB loss. There is only one diagnosis, isn't there? And here's the threshold, if you want to. From the left ear, the threshold's down at 73 dB. And of course, there is only one diagnosis. Okay? But there were many clues to this diagnosis. The chronic imbalance, these people don't get vertigo, except sometimes they cough, sneeze, or strain. But most of the time, they just have a bit of imbalance, and as well as the auditory symptoms, the autophony, hearing their own heartbeat, all that sort of thing. But they may not tell you about it. And if you ask someone, can you hear your own heartbeat, they'll probably say yes. So if you ask suggestive questions, you'll get positive answers. Very hard to do that. But so he's had a dehiscence all along. I mean, this doesn't matter. You want to leave it well alone, but at least you have an explanation. You're not going to start doing cerebral angiography to try and find something else. Okay, so point is that chronic imbalance, a superior canal dehiscence, very easy to find with VEMPs. OVEMPs will pick those up instantly, okay, because you've got the large responses. And here you can see here, I like the reconstructed ones, but here it is in a direct coronal, you can see it's there. Okay, now, some neurological causes of chronic instability. The chronically unstable are these. And there's a huge loss of neurology there, and I'm not here to, try and make you amateur neurologists, but you have to understand, you have to trust your neurologist knows this, okay? And, they have to be aware of the list. And if they're not, find another one. Okay, and we all know about multiple sclerosis, normal pressure hydrocephalus, a whole list of the most horrible progressive degenerative brain diseases, orthostatic tremor, which is important to diagnose because it's not serious, sometimes spinal cord things, particularly due to B12 deficiency, and a bad sensory peripheral neuropathy. Now, most neurologists will pick up the peripheral neuropathy. They won't have a problem there. But the other things, and MS, because it'll be obvious on the MRI. But some of the other things they'll have trouble with. So let me show you this lady, 67, sudden loss of balance, history of seizures, presented 1 week of 8 increasing ataxia, nausea, no vertigo, no other relevant symptoms. And apart from really bad ataxia and abnormal eye movements, she had nothing wrong. And here are the eye movements. Looking right, center, right, center. And what you'll see straight away is her adducting eye is too slow. She has slow adduction, which really amounts to internuclear ophthalmoplegia, but the only reasonable cause of that is multiple sclerosis. So you could actually make the diagnosis on the eye movements. But you've got to be familiar with looking at eye movements. And I can tell you most neurologists won't pick that. Right? That's just the reality. Okay, and here are some search coil recordings of the eye movements. And you can see here, this is, pointing the wrong thing. This is where the target jumps right, target jumps left. And you can see straight away that the abducting eye is fast, the adducting eye is slow. You can see it here in the velocity traces, the difference between the red and the green. That merely measures what you can see. But what I'm saying is that most neurologists aren't tuned to seeing that. If they're not, the easiest thing is to make a video and play it in slow motion. You can see. But it's very important. It doesn't matter if the patient's 67, they've never had optic neuritis or whatever, MS can present at any age. Now here's her VEMPs, her video head impulses, and there we've done it again with coils, and what you can see straight away is both posterior canals have a deficit, whereas the lateral ones aren't bad. Now the reason for that, if you know the physiology, has to be there, because the vertical vestibular-ocular reflex runs up the medial longitudinal fasciculus, which is the structure affected. So you can take it another way. If you think somebody has internuclear ophthalmoplegia and their vertical vestibular-ocular reflex is normal, they don't have internuclear ophthalmoplegia. Simple as that, is they've got something else. It's inevitable. Again, knowing the physiology and anatomy, you know those things have to go together. And this is very specific for bilateral internuclear ophthalmoplegia, is impairment of bilateral posterior canal function. We have to be careful, as what we said, is that although generally, statistically, age, you keep your VOR gain up with age, of course at 67, that's far too much. Okay, and that's just the same thing with eye coils, and you can actually see the difference between the adducting and abducting eye, because it affects, of course, the VOR as well as saccades, but you can see here that both posteriors are down, the anterior is a lot better. Okay, that is specific for internuclear ophthalmoplegia, and the same thing you can record with the odometric system. Here are both posterior canals down. And here are the VEMPs, and what you can see here is the O VEMPs are all gone, the C VEMPs are fine. And the reason for that is from the vestibular nucleus, the medial longitudinal fasciculus runs north, not south. So the medial longitudinal fasciculus, which is continue the medial vestibulospinal tract, is fine because the lesion is actually up in the brainstem. So the ocular VEMPs will be gone. And this is just another case for you to see, another internuclear. These are your neurologist will pick this one because the eye doesn't move. But they're not used to picking it, slowing of the eye movement, they're used to picking limitation of eye. That's a much more severe case. Okay, these will end up with off balance and they could end up with you. That's just another recording, again with coils, showing the bilateral posterior canal involvement. And this is, I won't detail, but this is the anatomy. This is vestibular nucleus going up the oculomotor nucleus. That, when you affect that, you affect adducting saccades, because here are the abducens interneurons, which supply media rectus, plus all the vertical vestibular-ocular reflex fibers. Okay, just to remind you, this is a nice little path specimen lent to me by Dr. Milder, and you can see here, there's the medial longitudinal fasciculus running under the aqueduct. For some reason, MS loves that. And there is the lesion on MR. Okay, there is the medial longitudinal fasciculus. So MR, you will usually pick these up. Okay, what have we got next? We seem to have halted. There are more slides. Why aren't we advancing? Oh, here we go. Okay, very good. Now, vitamin B12 deficiency, again, this is not otology, but you'd be very silly to miss that. It's completely fixable, right? And your neurologist will be aware of that. But it's very nice if before they go they've already got the B12 level. 99% of the B12s you order are normal, but it's still worth doing. This is a child presenting with an acute ataxia because the parents didn't give it any vegetables. And the MR is often positive. What you can see there is they actually have high signal in the dorsal column. Okay, but you shouldn't need MR to diagnose B12 deficiency. Now, the sort of B12 deficiency you might see are the people, I don't know if in Spain that's a habit to sniff nitrous oxide, but in certainly in parts of the Anglo world. And these nitrous oxide is sold in little capsules to make cakes. In my country, they're called whippets. And kids, usually university students, have a lot of fun sniffing nitrous oxide going ha ha ha. And if you keep doing that, you'll destroy your B12 and get this. So that's just something else for young people. Okay, now orthostatic tremor is a tricky one. The history is usually unmistakable if you talk to your patient. He says, "Doc, I'm no trouble walking, but I can't stand. The moment I stand, I have to hold on to something. I'm fine sitting down, I'm fine walking, but when I stand, I feel really off balance." And they won't say I'm shaking because the tremor is very low amplitude but high frequency. And here you can see the tremor there, it's 16 hertz. And that's just with EMG. They have a 16 hertz tremor on standing. It's typical. I go shopping at the supermarket, but the moment I have to wait in the queue, I have to keep walking. I get really off. And there are many neurologists who don't know this. And it's a very easy diagnosis to make. You can do it with EMG. You can actually put a stethoscope on the muscle, on the gastrocnemius. You'll hear it going grrr. Anyway, you don't have stethoscopes. That's all right. Okay, and here's the power spectrum showing that's this postural sway, and there is at about 15 hertz is the peak of the tremor. This guy, I don't know if we reported this years ago because he reckoned whiskey made it better. Most of them don't, and I think the reason was he wanted his health fund to pay for the whiskey. But anyway, so orthostatic tremor, well worth, but as I said, if you have time to talk to your patient, you'll be pretty confident on the history. Normal pressure hydrocephalus is a big problem in neurology and neurosurgery because there are lots of people who have big ventricles, but as you know, this guy has big ventricles but very little atrophy. So that's the clue on imaging, is the big ventricles, very little atrophy. They'll be off balance. And there'll be nothing obvious, they'll be off balance. Sometimes their memory is not so good, sometimes they have some urinary incontinence as well. When they have that triad, it's very suggestive. But the most suggestive is large ventricles without any cortical atrophy. And this is after a shunt, of course, it'll come down. The problem is that there is no specific way to make the diagnosis, and you keep putting shunts into people, you'll end up with subdural hematomas. But it's they will turn up with just off balance. And normal vestibular function. And again, here we are, someone spent quite a bit of public money looking at posturographic studies of normal pressure hydrocephalus. It means nothing. You can't diagnose it with posturography. There's nothing specific about the imbalance, no matter how hard you look. Now, these are now the absolutely horrible neurological diseases which kill you in a most unpleasant way in about 2 or 3 years. One of them you'll know is progressive supranuclear palsy. It's just awful. The clue with this often is the fact that they can't look down. So if you actually look at their eye movements, they have a downward gaze palsy. But the difficult one of this one, progressive supranuclear palsy or Parkinson's, is that they can present with just off balance, some falls, and nothing to find. You just can't, but they are definitely, say, I'm definitely off balance and I'm definitely falling. And their gait has usually become slower, but you've never seen them before, so you don't know this. Their spouse might notice too, but then, of course, their spouse might be walking slower as well. And that may be the problem. And again, I wouldn't get involved in this unless you have to, but I'm just warning you. If an elderly person says, I'm really off balance and I've become off balance in the last 3 months, and you find nothing, that is very bad. That is going to be one of these. But the problem for your neurologist, do you say anything to the patient? Say, look, I think you've got progressive supranuclear palsy and you've got 3 years to live. Great. So you have to shut up. Even if you suspect it, you have to shut up and just keep seeing them. Okay? Because you could be wrong. But the general rule is that the less you find, the more nasty it is. Just in passing, it's exactly the same as swallowing. If somebody says, I've got dysphagia, and you guys find nothing wrong, it's going to be something nasty. Unless it's, say, myasthenia gravis, but it's either going to be motor neuron disease or progressive supranuclear palsy. That's going to be real nasty. So it's another example where the definite symptom without any signs is actually an evil thing. That's quite a good article, probably written by Faye Horak with some Korean authors, What is Wrong with Balance in Parkinson's. Parkinson's is much more common than these other diseases, and we know quite a lot about it. There's, of course, postural abnormalities in Parkinson's. This is quite a nice picture showing that this is the lean forward or lean side. The top one is called camptocormia or head drop. This is called Pisa syndrome for obvious reasons. But these can be quite prominent in Parkinson's. And if you're not alert, you think it's some orthopedic problem. But the way to tell it's not orthopedic is that they can lie down. Nothing to do with the bone. This guy came to see us like that. He could stand up perfectly well with a chair behind him, and he was straight when he lay down. It's nothing to do with his bones. I found this article. It's a wonderful old drawing of that. I'm sure you see people on the street like that. Most of them have Parkinson's. Okay. What's this one? This is the Pisa syndrome. This is the side-leaning one. I just thought it was very cute. Pisa syndrome with about 18 Italian authors. I thought that was very clever. Okay. Now, what about this one, which we all love, is the chronic subjective dizziness. Isn't that good? Don't you smile when you think that's what your patient has? Oh, wow, another case of chronic subjective dizziness. Where is there any good work done on this? Well, this was showing that physical therapy helps, but, it's a bit like, sometimes sham surgery helps bad knees. But it's important. I think Dr. Staab writes very intelligent articles. He's a psychiatrist at the Mayo. And I think the evidence that these people are anxious and introverted wouldn't surprise any of us, but he's proved it. So, but of course, with all psychological diagnosis in neurology or in medicine, you've got to be careful the patient doesn't have something else as well. But I think that's quite a good article. It's believable. They sort of changed the terminology a bit, but this is about comorbidities. A lot of these people have vestibular migraine, and there's no doubt at all that migraineurs' balance is worse than non-migraineurs. And here's the definitive article from an author I know showing that, if you actually study them with objective measures, there is a worsening of balance in migraineurs. Now, what that amounts to in terms of evaluating a patient really depends on whether you suspect there's something else as well. Okay, so just because your patient has migraine and they're off balance, don't say, well, that's got to be the answer. It may have to be the answer, but it's a diagnosis of exclusion.